Surgery is often the first-line treatment approach for localized ovarian mesothelioma tumors. The goal of surgery is typically to remove as much of the tumor as possible without damaging nearby organs and tissues. For early-stage ovarian mesothelioma confined to one or both ovaries, a bilateral salpingo-oophorectomy may be performed to remove both ovaries and fallopian tubes. For more advanced stages where the tumor has spread beyond the ovaries, a tumor debulking cytoreductive surgery may be needed to remove all visible tumor nodules. This typically involves the removal of one or both ovaries, the fallopian tubes, uterus, portions of the peritoneum, omentum and other tissues. Cytoreductive surgery aims to leave behind no tumor nodules greater than 2.5 mm in size. When complete cytoreduction can be achieved, it has been shown to provide the best chance of longer survival. Even with an expert surgical team, complete cytoreduction may only be possible in around 60 to 70% of mesothelioma patients undergoing this extensive procedure. When widespread small tumor nodules are present throughout the abdominal cavity, complete resection may not be feasible to avoid damage to vital organs. In such cases where residual disease remains post-surgery, additional treatment is usually recommended. Chemotherapy is often given as an adjuvant treatment following a debulking cytoreductive surgery to destroy any remaining microscopic tumor cells not removed surgically. For ovarian mesothelioma, the combination of pemetrexed and carboplatin has emerged as the standard first-line chemotherapy regimen. Pemetrexed is an antifolate chemotherapy drug that works by interfering with folate-dependent metabolic processes essential for cell replication. Carboplatin is an alkylating chemotherapy agent that cross-links with DNA, preventing cell division and triggering cell death. Studies have shown treatment with pemetrexed and carboplatin results in superior overall and progression-free survival rates when compared to carboplatin alone. The combination of pemetrexed and carboplatin is typically administered in 4 to 6 cycles of 21 days each. During each cycle, patients receive pemetrexed on day 1 and carboplatin on day 1 of a 21-day treatment cycle. Dose reductions may be necessary in some patients experiencing toxicity from the chemotherapy. Close monitoring is important during treatment to watch for and manage potential side effects like nausea, vomiting, fatigue, low blood cell counts, neuropathy and others. Upon completion of chemotherapy, further treatment options must be considered based on the individual patient's response and the extent of disease remaining. For those whose disease has progressed following first-line chemotherapy, additional chemotherapy regimens may provide some benefit depending on the patient's tolerance and performance status. Monotherapy options that have shown activity in early clinical studies of recurrent, refractory ovarian mesothelioma include pemetrexed, raltetrexed, gemcitabine or vinorelbine. Multimodal therapy combining chemotherapy with immunotherapy agents is also a focus of ongoing research. For example, the anti-PD-1 antibodies nivolumab and pembrolizumab are under investigation for treating mesothelioma that has progressed after chemotherapy. By blocking the PD-1 checkpoint that tumors use to evade immune destruction, these immunotherapy drugs may help recruit the immune system to attack residual mesothelioma cells. However, more robust clinical evidence is still needed, and immunotherapy is currently not an established standard treatment option. For patients who are no longer candidates for traditional chemotherapy or cannot tolerate the side effects, less toxic palliative treatment options may be considered to relieve symptoms and prolong quality of life. Intrapleural therapies to deliver anti-cancer agents directly to the pleural space include intrapleural chemotherapy with drugs such as talc-slurry, bleomycin or cisplatin. Intrapleural heated chemotherapy with drugs like cisplatin or doxorubicin aims to enhance drug penetration using localized hyperthermia during instillation. Photodynamic therapy using photosensitizing drugs activated by laser light may also provide local tumor control. Symptom management with analgesics, pleura to prevent fluid accumulation, nutritional support and psychosocial care are important components of palliative care for advanced-stage mesothelioma patients. Clinical trials evaluating novel targeted therapies, Oncolytic viruses, tumor vaccines and other immunotherapeutic strategies continue to bring hope for more effective treatment options in the future. However, the inherently aggressive nature and chemo-resistant profile of malignant mesothelioma tumors makes them very difficult to control with currently available drugs and techniques. An individualized, multidisciplinary care approach combining all appropriate treatment modalities offers patients the best chance for longer survival and an improved quality of life when facing this challenging disease. Active clinical research efforts continue worldwide aimed at ultimately discovering a cure for mesothelioma. While radiation therapy can play an adjuvant role in some mesothelioma cases, the main alternative treatment approaches for ovarian mesothelioma include aggressive surgical site reduction combined with platinum-based chemotherapy, subsequent chemotherapy regimens for recurrent disease, investigational immunotherapy drugs, and palliative and pleural therapies or symptom management depending on the disease stage and patient condition. Both clinical trials evaluating novel agents and a multimodal team approach maximizing all appropriate standard treatment modalities continue to offer hope for overcoming this difficult